All right, welcome to Medical Grand Rounds. We've got a small crowd here in 217, but larger crowd online. Today we have, I think, a really exciting and interesting session. One of the cool things about UCSF is our graduates do amazing things in their careers. Sometimes they do it staying in academia, sometimes they do it going into practice. And sometimes they go into all sorts of jobs where they're making a difference in different ways. And I think, from my perspective, looking at the department, I'm incredibly proud of that. I think the key thing is that you're doing something you're passionate about and you're making a difference in the lives of patients and communities. And so there are lots of different ways of doing that. And we thought that it would be fun to talk to three of our graduates who have had really impressive careers doing that in work in organizations that are mostly about the health of populations. And so we have three illustrious graduates who have done that and made a tremendous impact. Two of them mostly in the public sector, one in the corporate business sector. So let me introduce them, and we will then bring them up. Two of them are actually live and here in 3 dimensions in San Francisco. One of them is joining us remotely. So the first is Tomás Aragón, who has served as the director of the California Department of Public Health and as the state public health officer since January 21. Prior to joining the California Department of Public Health, he was the health officer for the city and county of San Francisco and director of the public health division. And you may remember in the early days of COVID, Tomás was responsible for telling us all what we should and should not do, a job that was not without controversy, but one he performed incredibly well under a lot of pressure. He's had a variety of public health leadership roles at UCSF. And has also worked at UC-Berkeley. And Tomás was a resident at UCSF, I think in the primary care program based at San Francisco General, and graduated in 1991. And I was his chief resident. Yes, I was just about to say 1991 makes him very young. Tomás, why don't you come up to one chair? The next, we'll see if we can get Amanda on. I think hopefully that mic works. So Amanda Johnson, there she is, hi, is Assistant Vice President of Care Models in the Office of Ambulatory Care and Population Health for New York City Health and Hospitals Corporation. She previously served as Interim Chief Medical Officer at Sydenham Health Center and Director of the Take Care program within the Test and Trace Corp. And she currently leads Test and Treat's aftercare program for long COVID and provides integrated primary care and substance use disorder care. And Amanda was a resident at UCSF and graduated in 2017 and was chief resident 2017 and 2018 before taking her current role. So Amanda, welcome. Good to see you again. And I assume you're in New York. Is that where you're joining us from?
That is correct. Coming to you from the financial district of all places. That's where our offices happen to be. Fabulous.
Great. And our final speaker today will be Carmen Peralta. Carmen is Chief Clinical Officer at a company called Interwell Health, which is a value-based kidney care management company which uses big data and predictive analytics to build a patient-focused model of care. She was formerly professor of medicine at UCSF and co-founded and served as the inaugural executive director of the Kidney Health Research Collaborative. She completed an ambulatory care fellowship in 2006 and nephrology fellowship in 2008, both at UCSF. So Carmen, why don't you come up as well? Welcome. So there's a mic for you. So the format here is going to be a panel discussion without formal presentations, and then I will throw out a bunch of questions, but if you have them, please raise your hand if you're in the audience or raise your virtual hand if you're on Zoom. So let's go ahead and start. Tomás, why don't you start and tell us what a day in your life is like these days, and then we'll talk a little bit about your training and how you ended up where you are. But what is your? We can all read what it is, but I'm sure that has only a limited relationship to what you actually do. Is the mic not on?
Okay. Yeah, before I speak, first of all, I want to give a huge shout out to the UCSF faculty and researchers who just did a tremendous amount of work in really supporting the state. And when I was in San Francisco in the COVID response. So a good part of my time was actually getting the wisdom from people who who were studying the science. So we were incredibly grateful. And I have a long list of people that I wish I could thank publicly. But you guys have done a tremendous job. It's been a big had a big impact on us. So at the state level, came from San Francisco, which has almost 880,000 people, to the state level, which you have 40 million people almost. And so just the volume of issues that we have to deal with. So CDPH is part of HHS, Health and Human Services. There's 12 departments. We do all kinds of things. We regulate every single radioactive medical device in the whole state of California. We license and certify over 12,000 health facilities, including 400 hospitals and 12,000 skilled nursing facilities. So there's always something happening. We have a public health laboratory. We have occupational health. So the day is filled with meetings and putting out fires that come up. Sometimes they come from below and sometimes they come from the top. So just trying to be as responsive as we can to legislators, the government's office, as well as any public health issues that are just emerging.
Typical fire being an outbreak, or a typical fire being a report of a device causing a problem, or a political maelstrom somewhere?
It can be anything. Sometimes it can be things that are just very internal. So our laboratory does testing, large volume testing, and an issue will come up, and we will sort of drop everything to sort of make sure we fix the issue, just because it impacts so many people. And so sometimes, even just working out, example that we talked about a little bit earlier was just the COVID guidelines, for example. Team of scientists reviewing the guidelines, looking around the world, looking at other countries, looking at the science, the immunity and population, and deciding to update the guidance. So those are the types of things that just take a tremendous amount of time. So I still spend a lot of time on Zoom meetings.
Yeah, I'll bet. So before I turn to that too, I can't leave the COVID guidelines without asking at least one follow-up. So you changed the guidelines a month or so ago, basically saying a day of you have COVID, you've had a day of no fever and feeling okay, that you can go back into the workplace and go back to your, first of all, maybe describe what you did and then how you came to that. I'm sure it was controversial, and I'm sure there were different people that had different opinions about that.
Yeah, so what we did is that we're really, and this actually started when we came out with what we call the smarter plan for dealing with COVID. We really embraced a pan-respiratory approach. There's really multiple viruses that are circulating, especially during winter time. And we monitor the hospitals. We see the amount of activity that's happening. Every winter, we see the hospitals being overwhelmed. And for example, last year was an example where the hospitals were not overwhelmed with COVID. They were overwhelmed with everything else but COVID. So we've been following that. We've been following that carefully, the amount of immunity in the community, what other countries are doing. And so the way that we're approaching is, rather than thinking about specific viruses, think of all the viruses. You should not go to work when you're sick. Test yourself, because if you know whatever you have, if you have something that has implications for your care, the people that you're close to, where you're going to go to work, we want you to have that information. COVID really changed. When COVID initially started, every positive test came through a PCR. We knew who was infected. Now most people test on their own, and there's a lot of asymptomatic transmission. So we're really trying to get people to approach it in a more holistic way and to minimize the social disruption, especially in schools, where we really want to have kids in school. So that's been I would say the feedback has been mostly positive. We presented to state health officials several weeks ago. The CDC has also been looking at this. Oregon has already done it, and 14 other countries already do it.
And the pragmatic, this will be my last question about this, we'll move on, but it's so interesting. So people have asked me, okay, the state now says that after a day, you're on day 3 of your COVID, that you tested at home and you're positive and on day 3, and the state has said that I'm okay going back to work, let's say, because I feel okay now and I'm not febrile, does that mean I'm not infectious? And my answer is you probably still are infectious. A, is that wrong? Do you think differently about that? Or B, were you just weighing the trade-offs of if we don't let people go to work, they're going to not test themselves because it's really voluntary?
Yeah. So, I mean, if you think about sort of when you became infected with COVID,
yes,
you probably had several days before you tested yourself. And so the truth is, by the time you test yourself and you know your status, you've already gone through really your most infectious period, right? Especially because people are infectious, pre-symptomatic and asymptomatic. So most people are good proportion are asymptomatic. So most transmission is happening without it being linked to somebody who's COVID positive. So it's really that's sort of the tip of the iceberg. So we're not trying to control it at a population level. We're trying to right size our interventions. Our guidelines end up being translated into policies, sometimes health orders, and it has really real implications for people. And so some people will decide, I don't want to test myself because if I find out I'm positive, then maybe I don't need to, I'm not going to be able to go to work.
Right.
And so that has real economic and equity implications. And we would rather have people to remove the barriers, get tested so you have the information so you can protect yourself, your family, your loved ones, wherever you go. And so we do recommend that people wear a mask for 10 days once they find out. And of course, some people are going to get false negatives, right? So even if you get a false negative, it's a good idea to wear a mask anyway, because you can have another virus that can harm somebody else, or you can be a false negative.
Great. But it's interesting just to hear about all the considerations and the trade-offs that you're going through as you make these kinds of tough calls. I'm sure.
So one, I've told my staff, both when I was in San Francisco and at the state level, there's no absolute right answer. There are only trade-offs. And we're trying to maximize benefit and minimize harm, and recognize there's other things that we have to keep an eye on, like kids being in school, learning, and equity, and other things that might disrupt, society.
Yeah, great. Let's turn to Amanda. Amanda, tell us what your job is.
Hi, everyone. Well, I don't envy Tomás. I am relieved not to be in the hot seat on the latest COVID guidelines anymore. So as mentioned before, I work at New York City Health and Hospitals. And so I can run through what my day was like today and what's on deck for me after we complete grand rounds. But since it's not a Monday, I'm not in clinic. Monday is when I work at our federally qualified health center site in Harlem. It's called Sydenham. It was the place where I was interim medical director at the beginning of the pandemic. At New York City Health and Hospitals, we are a large public healthcare delivery system that's comprised of a multi-site federally qualified health center, 11 essential hospitals, skilled nursing facilities. One of our subsidiaries is a health plan that has a significant Medicaid line of business. We run an ACO. We have a home health business. So we are a large public benefit corporation, a health conglomerate of sorts, but with the express goal of providing care with dignity and respect to all New Yorkers. On my team, which is the Care Models team, yes, long COVID is a component of what we do, and it's part of the legacy of our work during the pandemic as part of the Test and Trace core. But my team really focuses on the care of people experiencing certain structural barriers to accessing the traditional healthcare system. So it's the care of people experiencing homelessness and the care of people coming back home after being in jail or prison. And so we have a couple of enhanced primary care models, a community health worker program, a street medicine program. And this morning, we spent in a retreat. And so my team was all on site today, and we subdivided into 3 groups. One is our enhanced primary care and community health worker group. One is our street medicine group, and the other is a group that kind of extends the work that was begun in these other places, but really with a focus on value-based care for people experiencing homelessness, and did kind of an annual plan. What are we going to do in the next 12 months? We had a team lunch. I hopped onto a meeting that we had with our street medicine program. We're the medical side, but we meet every other week with our behavioral health colleagues who partner with us on our street medicine units to deliver harm reduction services, connection to more formal chemical dependency programs if we can't provide MAUD or MOUD in the field. Now I'm here with you guys, which is wonderful. And after this, I'm going to go meet with our accountable care organization to talk about some interventions that are focused on the care of people experiencing homelessness. So how to manage low value utilization, promote engagement in primary care, address health-related social needs that are currently unmet. And then I will get into my in-basket and I will respond to some messages and check on the status of a few prior auths before going home.
Wow. You had experience here with dealing with the city and county and the Department of Public Health and its interaction with the university and it's kind of the way things work in San Francisco. When you got to New York, is it similar, just the scale being 10 or 100x, or does it feel different in some ways?
So the scale is different. I've also noticed that there are a couple of structural differences that really struck me when I arrived here. So in San Francisco, kind of understanding the San Francisco Health Network, Zuckerberg with its relationship with the community health centers and then with the consortium health centers, and its particular relationship as part of the Department of Public Health. In New York City, the Department of Health and Mental Hygiene is a completely separate city agency. And so whereas Health and Hospitals is its own public benefit corporation, and we can bill Medicaid, and we do a lot of healthcare delivery, and that is our strength in a public health response. There is an entirely distinct apparatus that's responsible for surveillance and food inspection and some of those other contact tracing for not just COVID, but other communicable diseases. And understanding how we partner with, but are distinct from. I also found it interesting in San Francisco, kind of the San Francisco Health Plan being more separate from the San Francisco Health Network in terms of not being an entity within. And, you know, we operate Metro Plus, we operate a health plan. And so kind of understanding the opportunities it allows us to partner with them on the care of our mutual patients a little bit more closely, but also, you know, they're not in this position of holding us accountable in the same way that an external payer could be. And those are relationships we have with other Medicaid plans in the region, other payers. But it's not just the scale, it's just that the landscape of healthcare is organized a little bit differently. I would also say that we wanted to bring a lot of things, and I still promote some of the great things that we do in San Francisco. In my kind of first and second year in moving to New York, I was really pleased to hear that we were bringing a Healthy San Francisco equivalent to New York City, and that was NYC Care, and it's a program that has grown by leaps and bounds, and we're entering a really interesting time because now in New York State, people who reach the age of 65 and are otherwise undocumented will become eligible for Medicaid. So it's nice to have a sustainable source of funding to provide for their care so that we can bring more people into NYC Care, or at least extend those resources in greater depth to the people who are part of that program. I remain a huge advocate of our medical respite and sobering center, and at every turn look for opportunities to see how we can bring some of those models into what we're doing in New York City. I would say that this perch also just means we have far more interaction with City Hall, with the Department of Homeless Services, with the community-based organizations who are providing homeless health care, with the Mayor's Office of Criminal Justice. And so these might be things that were totally happening at San Francisco General Hospital while I was a resident, and I just was shielded from it, but it's a regular part of the work that I do now.
And how much does the issues you're working on have healthcare dimensions, but also political dimensions, and probably getting increasingly hot in the political debate? How much does that influence your work? How much are you looking over your shoulder and seeing how things will play in City Hall or play in the daily news?
Yeah, I mean, I can't get away from it. It's something that I have to be thinking about all the time. I think one of the things that was fun about moving to New York and launching, my first project, which was just internal to New York City Health and Hospitals, and it was about a quality scorecard, is that people are going to tell you what they think. Like, you don't really have to, coax it out of them, and they're going to be pretty direct. And I came to understand that was them demonstrating their love and interest in what we were working on. Because at the end of the day, I think we were able to get to a reasonable solution and a balanced scorecard and all of that great stuff. But the way that the message was delivered was different than I had experienced in San Francisco. And I think the public sector is similar. I think that your constituents will hold you accountable, and you've got them at every level. You have community boards, you have a borough president, you have City Hall which has various offices. You have a mayor, you have other city agencies. And because we are such a complex city that's incredibly diverse, and we don't even run our own subway, that is a state apparatus. Like, you have to think about how those how the steps you take are going to interact others, and they're going to hold you accountable. So you should prepare for that. I would also say that during the pandemic, I learned how much being in the public sector was being in the public eye. And I think that was an incredible learning opportunity. After the fact, I got formal media training. But before that, they're like, all right, well, we need you to go to what we call the pressers. So going to some of these mayoral press conferences, because we want to see physicians owning the response to the pandemic. It is important for New Yorkers to know that they're in good hands, and it's on you and your colleagues to do that. And so
so you had not gotten any formal media training before they threw you out in front of the New York press corps?
If I did, I can't remember it. So it was really just kind of like, here you go, and here are the people who are ready to support you, how you prep for these things. And then there's some things you learn along the way, which have been really valuable and have allowed you to get a lot more fun out of the experience, but also to be able to see how your message can carry to deliver more important public health lessons, be a better advocate, because you're telling a story that all of these news outlets can pick up and tell in a way that is reflective of and has fidelity to your initial intent.
Great. Well, I have to say, I grew up in New York, and I think that's beautiful to say. When people are yelling at you, they're demonstrating they love you. I think that's really a nice thought. Carmen, tell us what you do. Right, again, should go. There we go.
Well, thank you so much for having me. It's really nice to be back. Feels like home.
Yeah, good.
And so my days are quite varied. Sometimes I spend my whole day on Zoom. Sometimes I have other meetings, and I often travel as well. So it kind of depends on what I'm doing. One of the fun parts about my job is, as Chief Clinical Officer, is I get to interact with a lot of different teams. So I may be on a call, for example, with the data team, trying to understand how to define certain variables or look at a data set and think about our outcomes. Or I can be in a meeting where we're thinking about improvement or refinement of our clinical models or implementations in different markets. Sometimes I might be in external meetings with clients or other providers or stakeholders across the country. And then I often travel, whether it's to new markets to try to understand them, or sometimes conferences and give talks about value-based care and kidney disease and race disparities and health equity. So I do quite a bit of that, which is great. And sometimes, like today, for example, I was editing a thought piece that I'm writing on something in kidney disease. And so it really is quite varied, and I get a great interaction of a lot of different teams.
As you were thinking about leaving full-time academia to move into the corporate sector, I know you were sort of weighing the trade-offs, and I think it's often hard to do that when you're in one of the sectors and you're moving to a different one. So how did you think about that choice, and what about being in the corporate sector did you not understand that you now have come to understand?
Yeah, great questions. So I was here at UCSF, as you said, as a fellow, and then on the faculty for over 10 years. And I always thought my path was going to be academic medicine. So get to full professor, go perhaps into administration or something. And so this opportunity came up without necessarily me seeking the opportunity. And my thought at the time, was thinking about, okay, is this an opportunity where I can take all my clinical experience and all my research to bring this voice as digital health and venture capital and all this investment is happening in healthcare and then in kidney disease. And so the way that I thought about it was, all this experience is going to make me a better voice. So I saw that my job was really to be the voice of the patient and the voice of the provider in executive meetings and investor meetings, and really bring that understanding. And part of my passion is understanding that kidney disease disproportionately affects persons of low socioeconomic status, race-ethnic minorities. And so to bring that view to understanding what are the fundamental problems in healthcare that we have to fix in order for the outcomes to be better. When I showed up in my job, it was, I started with a learning curve that reminded me of when in the old days we used to have to dose heparin or like replace potassium, and you're an intern, you're like freaking out because you don't even remember how to do it. That was me sitting in sometimes in meetings where people would say acronyms of all kinds, like MVPs and MLRs and all this, and I had no idea what they meant. And I would just write them down and have to Google them later and try to come up with that. And so my learning curve was enormous my first year. But then when I finally felt like I understood the payment systems and the incentives, it made a lot of sense on transitioning kidney care to a value-based framework. And I find that I often have to explain to a lot of people, spend quite a bit of time explaining the difference between a fee-for-service model versus a value-based care model, which I'm happy to do later. But really that understanding of how can we serve patients with kidney disease and focus on prevention, early detection, and the fundamentals of social determinants of health and all the other factors that we as providers know well impact the outcomes of our patients. So what did I learn in corporate? I learned a lot about incentives, payments. I have had to read a lot on just healthcare economics, behavior change, what makes a physician or a provider, a patient change behavior. Really, the other thing is the power of the omni-channel way to reach to patients. We get text, right? If you have an appointment here at UCSF, you'll get a text reminding you about your appointment. So even powerful tools like a text message or digital offerings are able to enhance our ability to reach patients. And I would say that one of the biggest things that I feel quite proud of is when we started at Cricket Health, which was the first company, the idea of how to reach the patients that were affected by kidney disease were always in the forefront. And I can't emphasize how important that is at the design level. So to give you an example, we had a digital program that was designed for folks to understand their choices around kidney health, around kidney disease treatment, home dialysis, transplant, so forth. So we had to think about how do we do it in another language? How do we do it in a maybe 6th or 5th grade reading level so that people can understand it, big font, audio, video, different learners. So that also was a really fun part of thinking about how to get more patients.
Is there something distinctive about doing this in kidney disease as opposed to a comparable company or set of companies doing it for heart disease or doing it for cancer? Is it either the issue of dialysis, the issue of transplant, the Medicare payment system for patients? What about kidney disease makes this special and changes the nature of the work?
Yeah, all the above. For those people here might be very familiar, but end-stage kidney disease is sort of interesting because back in 1972, there was an amendment that if you get diagnosed with end-stage renal disease and you need dialysis, Medicare will cover your costs. So we have provided care for patients with end-stage renal disease for all these years. And now the idea then was that folks that needed the treatment could now get a life-saving treatment. Now, what happened through the decades was that became a profitable business model around dialysis, and also the patient count increased tremendously. I mean, no one could have expected the epidemics of diabetes, obesity, and hypertension, and all the things leading to that increased population. So the focus had really been on this population that was an enormous spend for Medicare. So small population, enormous spend. And really the focus had been on end-stage kidney disease. So it's at the end of the road, so to speak, for the kidney function. We in the 60s and 70s knew little about the epidemiology of what we now call chronic kidney disease. And in fact, the name CKD was not something that we used when I was in residency. That was a nomenclature that the community came up with. So what's special about kidney disease is that there had been this focus on this extreme level of care payment burden for patients in the system on dialysis. What value-based care has done for kidney disease is literally transformed it to be able to pay attention at earlier stages. So the understanding that if we care for patients at earlier stages, they not only will be better, but less likely to go on dialysis. And even if they do, they now have a choice. So when a patient shows up in the emergency room and I have to tell them that they have end-stage renal disease and they need dialysis, that's a shock and many times a failure of the system when that patient could have got a preemptive transplant or maybe could have been set up to get dialysis at home, or better yet, slow the progression of their disease. So that I think makes kidney quite special because the economic incentive was switched. And then CMMI released a set of programs.
That's Medicare's
Medicare
Innovation Center.
Which have been incredible because they are shifting the focus to center the nephrologist of this care, earlier care for patients at CKD stage 4 or 5 and end-stage kidney disease, to shift around these value-based care concepts of prevention and delay. So it's been an incredible journey thinking when we started at Cricket Health, those programs the CMMI programs had not been launched yet. So we've been part of that entire ecosystem as it has moved from fee-for-service to value-based care, including the Medicare CMMI models. So I think that there's commonalities with other chronic diseases for sure. Just the payment system was particularly in need of innovation.
Mm-hmm. Yeah, it's this fairly unique thing where if you deteriorate to a certain point, there's a technology and a new payment system that's guaranteed kicks in. That really a parallel doesn't quite exist for other disease states.
Yeah, because we don't necessarily have coverage for like heart failure
or
cancer. Like people don't automatically get Medicare coverage like they do.
And when you say value-based care, so you or your company is getting paid a fixed amount of money for a given patient, and if you can keep them healthy and keep them off dialysis, you do better? Is that the concept?
Pretty much. Value-based care is many different types of payments, but the essence is that. So in fee-for-service, you're going to get paid for volume, for each visit, for each procedure, for each thing that you do. In value-based care, the idea is to incentivize so that the payment system is aligned with the outcomes that you want to see, i.e. slowing progression, folks not being in the hospital. No one wants to be in the hospital, it's expensive. Focus on preventable hospitalizations. So to the degree that you can then reduce those costs for the entity at risk, meaning whoever is going to foot the bill for that is going to be beneficial for that risk-bearing entity and for the patient. So that's a very high-level conceptual framework of value-based care. Many different types of contracting can do that, but that's the essence.
Maybe one more question about you getting into the corporate world and sort of seeing it. I mean, you've painted a picture. I'm a little worried that everybody who's watching would say, "Oh, sounds great." That that I'm sure there's a lot of money sloshing around, more than I was used to in academia. You don't have to write grants, and I've been able to really follow my dream, taking care of patients with kidney disease and thinking about value and thinking about social determinants and disparities. So it sounds great. I'm guessing there's a part of it that's like, we got to demonstrate a profit. The venture capital people, this is not charity. They want to see outcomes. Wall Street's looking at us and all of that. So can you describe a little bit of that, and how did you come to terms with those issues?
Yeah, really great question, Bob. You weren't going to let me get
off. I'm not going to let you. I'm just worried everybody's going to go to sign up with your company.
Everything in life has positives and negatives, and everything is a trade-off. So there's a lot of things I miss about academia and being at UCSF. Our research group, our ability to concentrate on the research question that I was passionate about and writing my grant and getting my grant to do so. So here is very different. You don't just pick the thing that you want to study and you write a grant and they give it to you. You really have to think about, well, what's the ROI? What's the business imperative for this? And that's always an issue. Certainly the issues around investment, venture capital has invested billions of dollars at this point in value-based care, but in particular in kidney. So there's definitely a lot of pressure on that side. The payers are looking all the time to make sure that we are actually saving them money and that the outcomes are better. So there's definitely a different culture, a different type of pressure that, it's just completely different to get used to. What I think about it is that if I kind of go back and say, okay, where do I think I can make somewhat of a difference? And staying in the fee-for-service world didn't seem like it was going to systematically have the opportunity to fix things. Will value-based fix everything? I don't know. I think it's to be determined. I think we have great outcomes and we're seeing good things, but there's still a lot to know. So a way I think about it is, this is a system that really has the potential to change things. And so as long as we keep the quality incentives aligned to the things that we know are right for patients, then the rest of the issues you can move forward and keep your North Star. That's at least how I.
And do you think are the quality incentives okay now? The trick about, as you say, you flip the script completely, and now the incentive is to spend less money. And the concern always, of course, is you spend less money, but you're skimping on care that patients actually need.
Oh no, yeah, I mean that is certainly a concern and something that people bring up, but in these contracts and these type of arrangements, we have a lot of quality metrics that one is also held accountable to. So it's not just the financial, that's certainly a big part of it, but there's also going to be quality metrics, like in kidney world will be, for example, less use of catheters to start dialysis, or improved access to transplant referrals, or so there's going to be quality metrics related to a better quality of care.
Okay. I'm going to open it up to the folks here. I want to do one more quick round and ask you about your training and what you think we got right and what you think we missed that we should have taught you. Obviously, Amanda, we should have done a little more media training. And, obviously, I'm hearing Carmen talk about this. I don't think it would be reasonable to be training people on all of these acronyms about payment systems. Probably you have to define yourself as that's what I'm going to do before you have a need to learn. But as you reflect back, what do you think we got right, and what do you think we could do a better job on, given what you see in your career? Maybe, Amanda, you want to start?
Why not? So I credit so much to UCSF and the SFPC program for even getting me to the place where I am today, and full credit to the Heath pathway. I know that they do media training, but I was in health systems leadership, so that was a trade-off that I made, and I would just have to learn that lesson later. I think some of the things that I appreciate most do relate to clinical practice, and it might seem odd to start there in a conversation about public service careers, but it was still really important to me to be a doctor, to be somebody's doctor, and to offer them the best that I could offer. I felt like I had such a gift in this training, and I wanted to extend it to more people who didn't live in San Francisco, people who didn't live in California, completely different context. And, when you're in clinic, and when I started, I was doing 2 days of clinic a week and a month of inpatient, like you have fewer hours in which to get your reps in. But I really appreciated the training that I got that allowed me to apply clinical reasoning in the outpatient setting, understand where my comfort level was, understand how to fill in my knowledge gaps, because I would say that my access to specialists being in a community health center was not the same as it was when you're practicing primary care in the hospital setting. So it's like, all right, well, this is the first time we're going to do sudden sensory neural hearing loss in the outpatient setting, but I feel ready for it. And so I appreciate, my instructors by giving me the footing to be able to do that while still trying to establish this other skill set in this interface between healthcare delivery and government. I also really appreciate some of the tenets of development that I gained at UCSF. So as a senior resident and as a chief resident, how to give feedback all the time. And I would say that one of the things that was striking to me when I was doing inpatient practice is, that the appetite residents had for feedback that they weren't necessarily getting, or at least not getting in kind of that highly kind of objective and development-oriented, adult learning theory grounded way that we do it at UCSF. I could go on and on about all of the things that I appreciate from this time. I would say one thing that was different for me, and maybe these were kind of skills that you're really pressed to develop as an intern, but when you become a developer of people, you kind of, you hold off a little bit, or you lean back. When we had the pandemic, we were at kind of the, not necessarily the surge of COVID, but when we were entering kind of the suppression phase and we were beginning to build a contact tracing apparatus, and my particular responsibility was isolation and quarantine. What are the supports we're gonna develop to support people who are at home, as well as what spaces could we offer to people who couldn't isolate or quarantine safely in their, multi-generational crowded New York City apartment. It's your job actually to be the voice and the decision maker. And so some of like my early coaching was like, it's great that you are smart, but we don't need you to be like smart and quiet in the background. So you're representing all of us in this meeting, and it's your job to talk. You don't have to be an expert. We will brief you. You will get to ask your questions, but when you get in the room, it's your responsibility to talk, and you don't have to wait until everybody else has a chance to go around. Like, much to Carmen's point before, like, you are the patient voice, you are the provider voice, you are the healthcare system voice. So kind of step up to the mic and take charge in ways that I found myself doing less the more senior I became, because your job in a lot of circumstances is to allow others to develop. But when you're in kind of a crisis situation, people need clarity and direction.
Did you feel like you were trained and socialized to be that person who has, you're kind of describing executive presence? Was that something that came through your training, that you felt like you were well prepared when you got to your job in New York?
I think that when it came time, I was ready to switch. I think that things like our approach to M&M, not just delivering them, but also facilitating them, are opportunities to practice what it's like to be in the spotlight or on the hot seat. And those were some of those memories I had to reactivate. And I was like, oh, wow, there's actually not like an individual person on the line here. Like, let's talk about it. One thing that I would often say to my team during the pandemic, when they would come to me with an emergency, is like, okay, well, tell me what's going on. Do they have a pulse? Are they breathing? Like, okay, well, it's actually not an emergency. We have some time. And so I think part of the strength that I was developing was also being able to push back on what we were going to let kind of consumer attention and get us to spiral versus what is something we actually had hours or a day or some amount of time to work on. Yeah,
you're learning to calibrate your reaction, and not everything's an emergency. Sometimes take your own pulse. Carmen, what do you, now as you look back, you're training here, and I think you did your residency somewhere else, but what do you think that we missed, and what did we do well?
Lots of things that are good, that were done really well. I feel like the thing I'll say is most of the people that I ever worked with at UCSF, the sense of excellence in your work and pride in your work and pride in how you take care of patients. I think that's huge. You were asking me about the differences in culture and shock. And I think one of the things is the North Star. Like here, in our research group or in clinical care, there was a North Star of what you wanted to achieve. And you have to be really passionate and secure in that North Star, because there will be forces around you that will absolutely derail you. And I think that what I got at UCSF was great mentorship, because that happened in research all the time. You get a paper rejected, you get a grant that doesn't get funded, like all these things, but also you're going to have to be compromised in where you spend your time, attention, and all that. And I think that was incredible from that perspective. There's also the sense of community. I think that is good, and the sense of building people up. I think that's also huge. As far as what we didn't do as well, I really do wish that we had some understanding of the business and economics of healthcare. We don't need to know all the acronyms and everything, but I really do wish that there had been a forum where people could at least explain the basics of these systems. Like, how does a health plan make money? How does a private practice make money? How do, just very basic concepts. And for good or bad, we live in a system where it is a capitalistic system and medicine is a business in this country. We can have a whole debate about that, but it just is what it is. And so the question is, how can you be part of the system and be the agent of change? And that's one thing that UCSF, I think, does instill in us, especially those of us who were here for so long, that you are and you have the responsibility to be an agent of change, kind of like what Amanda was saying. So it is part of the mandate. And if you're not able to be an agent of change, then you need to figure out some other thing to do, because that should be your mandate.
Great. Tomás, anything you want to add about training?
Yeah, so I thought my training here was fantastic, both clinical and research training that I had here at UCSF. There's two areas that I want to just summarize briefly that sort of has frustrated me. There is a big gap between research and practice. And sometimes the academicians don't understand this. So in public health, things move so fast. We're going to make decisions whether you have evidence or not, because we have to make decisions. And so sometimes academicians want to help us, but they move way too slow.
They either don't have a grant, or the p-value is not quite there, or something.
Yes. They move too slow. But where it has worked, San Francisco is actually a pretty good model. This is where UCSF partnering with local public health And what you have to do is you have to work with them. And the better the situation is where you're embedded in public health practice. So you begin to develop, iterate, and sort of figure out how to come up with a minimal viable product. MVP, not most valuable player.
Right.
But in practice, when you're dealing with real public health issues, and I think we need more of that in public health. So San Francisco is a good model. We want to UCSF, SFDPH. We want more of that across California. So having that gap. Well, the other thing that UCSF does really, really well is that you have an amazing program in implementation science, because that is the challenge. How do we translate evidence into real world practice that takes into account psychology and behavior, complexity, all of these things? And I think this is where UCSF is a leader in implementation science. And so we're actually training our public health staff in implementation science.
Great.
And so that's an area. And the last thing I just want to mention is sort of in that area of psychology is just team skills. If you sort of think about as you move up in an organization, there's certain things, there's skills that always serve you well, no matter what level of the organization. So I tell our staff is teams and meetings are laboratories. That's where you get to practice your leadership skills, your management skills, your people skills. You can test hypothesis. So you have a way of really developing that over time, because those skills will serve you whether you're an intern on a ward or whether you're a CEO in an organization.
That's great. That's great. Yeah, I think people sometimes don't understand that the skills that you learn running a ward team of time efficiency, bringing the team together, giving people feedback, asking tough questions, they serve you well in every part of your life, no matter where you are. You're making a difference. That's terrific. Let's throw it open, see if folks have questions either here in the audience or in Zoom world. Watching anything?
We have over 60 people tuned in. One of the questions is really about how do you all get feedback on the work that you're doing? You talked about like feedback to the latest COVID plan. And then Dr. Johnson talked about feedback that she gets from the public. You talked about feedback for your investors. So how do each of you all process receiving this public feedback, sometimes very public, with positive and negative?
Must want to start with that, because in some ways you got the most feedback.
Yeah.
For the early days of COVID, you were absolutely in the hottest seat.
And that's when people sort of ask me, what's it like being a public health official? I say, well, every decision, everything is public and scrutinized. And so it is challenging. So yeah, people are not shy about giving me feedback. I get tons of feedback, and community engagement is sort of part of how we do things in public health. So during COVID, there was a both at local and state, a large amount of feedback from folks. And so you do want to institutionalize that and make it as a regular part of practice. I would say one of the challenges in a leadership position, as you climb higher in your leadership position, people give you less feedback because you're now a leader, because there's
or they just tell you you're wonderful and you haven't made any mistakes at all.
So I would say part of your team skills is actually making sure that you build in a practice of to create the psychological safety in your team meetings so that you get feedback, including on your performance.
What would you say to people to get them to tell you when they think you're making a terrible mistake?
I will, one is you want to get feedback from trusted sources who care about your developments. That's one thing. And I'll tell people, am I thinking about this correctly? What am I getting wrong? Let me know. The other thing I do is, it's sort of general, is that I usually say silent. I'm the last to speak because I want people to be completely honest. And when they give information that's maybe not part of what people are thinking about, that you say fantastic. I think in a leader, you have to be proactive about seeking feedback, because people really do become quiet and don't want to give you feedback. So you actively have to work.
Yeah, must be a strange disconnect, because I think in your world, and maybe it's much more so in COVID there's never been anything like that in terms of the level of public engagement and scrutiny. You have this internal environment where people may just be saying, oh, that's great. And then this external environment is like a hurricane, like everything you do. People are going ballistic, but that's wrong. And how could he said we need to stay 6 feet apart? Where did 6 feet come from? And all that kind of stuff. It must have been a strange disconnect. Carmen, what do you think?
Yeah, I think that's a great question. I agree with you that as you get higher, you get less feedback and you have to seek it. I think one of the things I've learned is you're not going to necessarily get the feedback when you want it or need it. Like if you're insecure in a decision, you know, a lot of the times we have to make some of the differences, make decisions with very limited data, and we have to be okay with that. And admit that it may be wrong and that we need to pivot. And so I think some of the best feedback comes from understanding when things didn't work out. A project didn't work out. It didn't really, happen as you had thought or directed. What I do, and this is more maybe like an emotional thing around feedback. All humans, I think, well, at least for me, I need feedback. So I sometimes just, will listen and to the nurses tell us stories about a patient that needed a ride and they were able to get to where they needed to be, just because sometimes that's enough to keep me going because I haven't really had any other positive feedback. Everything's like pressure to get things done. So I do think that there's a mental health, a wellness component in seeking the feedback of, are you really getting impact to the folks, the communities that you're really thinking about? And then the rest around career development, you have to ask for it. I have found that people don't just come volunteer. You really have to ask for it.
And do you ask for it from people within your own company, or do you sort of have a stable of friends and family on the outside who can help you think about things outside of the corporate environment?
Yeah, so sometimes people from my own company, but I've also been developing relationships with folks in other companies or maybe investors, and get feedback that way. And it's useful to get feedback on professional development from people who work with you very closely, and also people that don't, so that you can understand how you're being perceived kind of in the outside world.
Okay. Yeah, great. Amanda?
So one thing that we have done on our team as part of one of our initial kind of like team building activities was having a session around what are the ways in which people want to receive feedback. And it was at least helpful for level setting. And I know kind of who is feedback avid. And I've also kind of communicated that like, I want feedback, but I'm probably not going to ask for it because of, insecurity or pressure. So I need a little bit of help with that. To try and compensate for that, I've been pretty explicit around some of the things that I want more feedback on, like executive presence, quick decision making. Like, am I getting you information on the timeline that you need to act on it? Public speaking, and then I tell my team I'm working on my comedic timing all the time, so I need to know. I need to hear the laughs in the room if this is actually landing. I have also been able to just develop smaller circles where I can be more vulnerable. So, I have a chief of staff on my team. I have a kind of senior staff level meeting that I do every couple of weeks so that we can be a little bit more kind of candid, because I think what Tomás said is right. It's like you get less feedback, and you get less feedback for a variety of reasons. So how can you start to, at least in small ways, subvert or flatten that hierarchy so that people are going to be a little bit less intimidated? But I would say that, I've been out here for 5 years since residency, and I'm still at a point in my career where I want and need more feedback. And I think Carmen's correct that sometimes it has to come from people who are outside of your immediate orbit. The other thing I will say about feedback is that not all feedback is good or useful or desired. And I think that there is also this component of like self-reflection, self-study, my own personal practice around self-improvement on a variety of dimensions that I do, so that when I'm getting feedback that maybe is coming from like a long ways away, someone from the outside looking in, and I can process it and say, okay, what are the kernels of truth here? Like, what do I want to incorporate? What about this outcome might I want to avoid in the future? Versus, what am I okay living with? Like, yes, maybe you don't agree with this decision, and maybe my recommendation wasn't the one that we ultimately decided to use, but can I stand behind the stance that I took? If that is true, that is also what is important to me. So I think being able to say that I'll take the feedback, but what's more important is kind of integrity, authenticity, sense of self. There's a role for that too.
Great. Any other questions out there? I can't help ask a question that you can decide to answer or not answer, but you're all from groups that are underrepresented in medicine. I'd be interested in how that has changed your perspective, changes it sort of in terms of your day-to-day work. Carmen, you want to start?
I think it's an important factor. To be honest, it was part of my considerations when I decided to make the leap from academia, because the reality is that in traveling the country, raising money and talking to people, there were not a lot of people looking like me.
Mm-hmm.
But we do have a lot of patients who look like me. And so I felt that that was something that I kind of needed to dive in and be part of, because if not me, who? I mean, not to sound like all full of myself, but if not us, who?
Sure.
And so, yes, I think the other thing to think about is that the corporate world is a world that is still very much dominated by represented groups, and so it's definitely a cultural adjustment to be there. There's no doubt about it.
More than academia, or different? How is it different than academia?
It depends where you are in academia. So I think, and UCSF is quite unique. We are more diverse than others, but I mean, in academia, still in the leadership positions, chairs and dean and so forth, there's less representation, but I think it's probably a little bit better. At a place like UCSF is definitely better than the overall corporate world.
Mm-hmm.
So I do think it's an issue in that way. Many of us have understood how to make our voices heard in different ways that allow us to get our message across, but that can sometimes be very difficult. And also, one thing people don't really talk about too much is, like, from where we come from, at least from where I come from, I don't have a family that's connected to venture capitalism in the corporate world. So I can't just call my family and give, I had to make a name for myself in academia. I had to make a name for myself. And I think it's a very different experience, not to discount one or the other. It's just very different in the distance traveled to get into those boardrooms and to get into those executives.
And then when you got into that boardroom and you saw a group of VCs, there were all white guys, how did that change how you presented yourself? And did you learn lessons about that over time?
Yes and yes, in that I just understood that I had the expertise and I knew the data.
Mm-hmm.
And so once you're able to present a coherent, good business plan with data to support it, you can walk in the room secure of yourself and be able to voice that. And so from that perspective, I felt that I could, because I had the expertise.
Mm-hmm.
I've mostly been quite welcome, I'm sure, but it's definitely been an additional effort to build a community that wouldn't have naturally been one that would have happened in my life organically.
Great, thanks for sharing that. Tomás, how's it been for you?
Yeah, thank you. Really good question. I'm going to say it in two different parts. The first one is, yes, Latinos are absolutely underrepresented in medicine and public health. Close to 40% of the population in California is Latino, and about maybe 6% are physicians, and even less so in public health. So there's a big underrepresentation given the amount of how big they are in California. So that's one issue. So so my family immigrated from Central America. My mom only had a 6th grade education. So I was very fortunate not to have a lot of pressure that other people have. Mm-hmm. My mom's requirement for birthdays was just, she would say to us, my only wish is that you be a good person. That was the only pressure I had. And so it's fantastic.
Sweet.
So, and I want to just mention one of the things about being in governmental public health, while we do focus on the most vulnerable and we know that if we raise those boats, we're going to raise everybody's boats. They call that targeted universalism. We still are interested in every single person in the state of California. No matter where they live, everybody deserves public health services. And so I think we have sort of a unique role where, yes, we do focus on the most vulnerable, but at the same time, how do we make sure that we reach everybody in California, people, including people in rural areas, for example, who oftentimes don't get the services or have to travel a lot farther. Hospitals are closing because they're under financial stress. So we have that unique lens that we have is that we still have to remind ourselves that we serve everyone.
Great, thank you. Amanda, we'll close with you. Any observations?
Yes, I mean, there is an incredible power to being that person in the room who, when you're having conversations about pipelines, who can speak to what it's like to come from a background where you don't have other physicians in your family, where it requires this leap of faith to take on a really kind of intimidating amount of debt that you don't know you're going to be able to pay off, like what that materially means when people are then at the end of that journey and trying to decide where they're going to work. It's also very interesting to do some of the translation across clinical contexts, which are actually majority staff from minoritized backgrounds, because that is the landscape of kind of public service workers in New York City of our kind of 45,000 employees. Like it's very different to plan this central trauma-informed care, racial justice and equity training that you don't understand is actually othering your patients, because your workforce is actually has affinities with the patient population that you're not perceiving. So how can we make this a little bit more relevant to the work that they're doing on the ground? I would say that one of the honors of being in this type of position is that on days where I am kind of feeling run down or not sure where all this is going, or if I'm making the impact that I want to have, I've had people come up to me and say, like, I don't see other Black women at central office as much as I would like to. It means a lot to have you in this role. So thank you, we admire you, we see what you're doing. And kind of that's all you need to remember, that you are in the right place, and to be reminded of what your North Star is. So it's an incredible honor, as much as it can be trying to manage all of these intersecting identities and responsibilities, but it's a gift to have the chance.
Well, thank you. The three of you have done, it was a wonderful presentation. Also, just we're very proud of the things that you've accomplished and the difference that you make every day. And I think you demonstrate there are a lot of ways of making a difference, and none of them are any better than the others. You need to find your passion and follow it and do good stuff. And you're all doing really good stuff. So thank you so much. Really appreciate it.